Assalamualaikum warahmatullahi wabarakatuh. Welcome to the master video. So the previous video I have kept the name as master video 1 for arrhythmias, and this will be the master video 2 of arrhythmias. Okay, so in this video we will speak about, just a minute. In this video we will speak about master flow charts of arrhythmias. I have discussed this in part 4, but I have related it because flow charts are there, but the concepts were not clear. So I thought of making some first understanding some of ECGs of this SVTs and VTs. Then we will go to moving on to the flow charts will make it easier. So let us understand. Let's begin with the name of Allah. So first you see, whenever there is narrow complex less than 3 small squares QRS, okay, what you will see, you remember the mnemonic hearts, no, in the previous video. Okay, but when you are seeing any tachycardia or bradycardia, when you're seeing, see whether it is narrow complex. If it is narrow complex, see whether it is regular. See, if it is irregular, then there are only 3 possibilities. Narrow complex tachycardia with irregular rhythm, only 3 possibilities. Either it is atrial flutter, or it is atrial tachycardia, or atrial flutter with variable AB conduction, or it is multifocal atrial. These are the, you need to, what you all need to ratta this thing, you need to store in memory this thing. So regular tachycardia, irregular, sorry, if it is irregular narrow complex tachycardia means only 3 possibilities. Either it is AFL with variable conduction, or multifocal atrial tachycardia. How we will differentiate between these three? So in AF there will be no P waves, no P waves will be there. In AFL you will have flutter waves. Okay, in multifocal atrial tachycardia you will see different morphologies of P waves. Some will be like this, some will be like this. So that's how you differentiate irregular narrow complex tachycardia. So that is a good thing. You should be happy when you are seeing irregular narrow complex tachycardia, because they are not much harmful, and you can give adenosine. Okay, that is therapeutic also, and that is diagnostic also. Now if it is not regular, it is not irregular, it is regular, then the possibilities are AVNRT. In AVNRT they can be typical and atypical, no? There are 2 types, typical and atypical. AVNRT. Number 2, AVRT. Number 3, atrial tachycardia. But in addition to that, you can also have AF and atrial flutter or atrial tachycardia. Atrial flutter you should exclude, because atrial flutter can present irregular also as well as regular also. Both it can present. When there is most commonly it presents as regular only, atrial flutter, but in sometimes when there is what you call variable conduction of the AV node, it can present as irregular rhythm. Most commonly it will present as regular only. Okay, so from AVNRT, AVRT and AT, first you exclude that atrial flutter. So narrow complex tachycardia, regular rhythm, no P waves, then it is AVNRT. No P waves, then it is AVNRT. Which AVNRT? This is typical AVNRT actually. No P waves, typical AVNRT. Okay. Regular tachycardia, narrow complex with no P waves is nothing but AVNRT. Oh yeah. If there are P waves, narrow complex regular tachycardia with P waves, then it can be all those SVTs, or it can be atrial flutter also. Now you calculate, if there are P waves, narrow complex, regular, narrow complex, it can't be VT. It's okay. So you calculate atrial rate and ventricular rate. If the atrial rate is more than ventricular rate, then it is atrial flutter or atrial tachycardia. Atrial tachycardia. Atrial tachycardia, how we will differentiate? Morphology of P wave will be changed. It is also changed in atrial flutter. Okay, but here you can find flutter waves in atrial flutter, and the rate is very much high, 300 to 400 beats per minute the rate will be, but ventricular rate will be there, okay, normal. So atrial flutter, if atrial rate is greater than the ventricular rate by seeing the P waves and R waves, then it is atrial flutter and atrial tachycardia. So regular narrow complex regular tachycardia with P waves. This is the differential with P waves. Regular narrow complex tachycardia, regular narrow complex with P wave, and one is without P wave. So if it is without P wave, it is directly AVNRT. But if it is with P wave, then you should first exclude atrial flutter. Okay, how we will exclude? If the atrial rate is more than ventricular, then it is atrial flutter. If it is not like that, there is no, okay, regular narrow complex tachycardia with P waves, you need to evaluate further. Without P waves, directly AVNRT. Okay, so first you are excluding atrial flutter by calculating the atrial rate and ventricular rate. If it is not like that, atrial rate is not the ventricular rate, okay, then you should differentiate. It is not atrial flutter or atrial AVNRT, AVRT and AT. How you understand? Main thing is RBBB. So the I will just key points in this chart is whether it is regular or irregular, whether it is narrow complex or broad complex, whether there are P waves or not, and whether it is analyzed R. These are the 4 key points in SVTs to analyze the ECG. Okay, regularity, wideness of the QRS complex, P waves and RP interval. These are the 4 things of SVTs. So analyze the RP interval. If the RP interval is long, then there are only 3 possibilities. Okay, 3 possibilities. If the RP interval is long, RP interval long means the P wave will be abnormal, it will be behind the QRS complex, like this. This is T wave, this is P wave, again QRS complex, this is P wave, again behind the curve, like this. So RP means from the starting of the P wave, from the starting of the R wave to the starting of the P wave, this is RP. If it is more than PR, what is PR? From P to R. Clearly I will draw here. Okay, this is RP and this one is PR. Okay, this is PR and this is RP. You see, RP interval, if it is more than PR, then it is only 3. Atypical AVNRT, just remember this. Mechanisms I have already discussed. Or it can be AVRT, orthodomic conduction, slow pathway, or it can be atrial tachycardia. That's all. Now if it is vice versa, RP is less than PR, 70 milliseconds in the sense I will say 20 milliseconds is equal to 1 small square, 1.5. Okay, so if RP is less than 1.5 small squares, then it is AVNRT. And if RP is more than 1.5 small squares, then it can be again 3, AVRT, Atypical AVNRT or AT. Finish, over. That is SVT. Okay. Now we will move towards wide complex tachycardia. Key features already have mentioned here. AV dissociation. Capture bits, fusion bits are the hallmark of AV dissociation. Very wide QRS complex, meaning more than 200 milliseconds. If you think more than nothing but more than 5 small squares. Very wide QRS complex. And atypical BBB morphology. Atypical rabbit pattern in the previous class. Right ear is more than the left ear, or in the V1 it is monophasic R wave, and in V6 it is small R and S pattern, like this. Small, this small R, and this is S, like this in V6, in V1 like this. So this is atypical BBB morphology and a history of structural or heart disease. Assume VT until proven otherwise. When it should be regular. One important point here. So we are decoding this one. So wide complex irregular tachycardia, be happy. Wide complex irregular tachycardia, be happy, because it is either atrial fibrillation, or it is either atrial flutter or atrial tachycardia with variable conduction or aberrancy, or rarely it is polymorphic. Here you should not be happy. That is very typical, no? Twisting around the points. Okay. So wide complex tachycardia with irregular rhythm, happy. Okay, because it is something AF or AFL which is having aberrancy, that's why it is presenting as wide complex tachycardia. But if it is regular wide complex tachycardia with regular, then you should differentiate now. Now, one first thing you should, if the patient has some previous ECG, and in that previous ECG, the QRS complex is identical as in sinus rhythm. If it is yes, then it is SVT with aberrancy or antidromic means accessory pathway, AVRT. Patient is having wide complex tachycardia if there is available previous ECG, and in that ECG the QRS complex is identical to sinus rhythm, then similar to this ECG, that ECG, the QRS complex, both QRS complexes are similar, then it is nothing but SVT with aberrancy. Okay, remember, compared with previous ECG. Now, or if there is any history of MI or structural heart disease, very likely it is VT. Very likely it is VT. So 2 points you are asking. 1 point, second point, then third point is whether there is AV dissociation. This is the third point. AV dissociation. So if there is AV dissociation, ventricular rate will be faster than the atrial, and if ventricular rate is faster than the atrial rate, then it is VT. What happens in AV dissociation? Atria will be depending upon their atrial beating upon their own heart rate, and ventricles will be beating upon their own heart rate. Okay, no fusion or capture beats. Okay, then you calculate the atrial rate and ventricular rate. If ventricular rate is faster than atrial, that is VT. If atrial rate is faster than atrial, it is atrial flutter or atrial tachycardia. No, the conduction is 1:1. More likely it is SVT. If see the QRS morphology in the precordial leads, very important, from V1 to V6, and also 1 AVL you should consider. These leads are very important to differentiate. Okay, so if there is AV dissociation, calculate the atrial rate and ventricular rate. If it is ventricular rate faster, then it is ventricular tachycardia. Atrial rate faster, then it is AFN or AT. No, what it is when 1:1 conduction, then you see the QRS morphology in the precordial leads. Okay, typical RBBB and LBBB pattern. What is typical RBBB pattern? We have learned in the previous video. Typical RBBB pattern is you will have the rabbit ear right side, right point of the rabbit ear will be tall. Okay, and you will have W pattern in 1 AVL and V6. one AVL and V6 ULW pattern, and left ear in V1 and V2, left rabbit ear will be tall than the right ear. Sorry, right rabbit ear will be taller than the left ear. So this is typical RBBB pattern. Then that is SVT. Okay. You search for typical. If there is no AV dissociation, conduction is 1:1. You search for this typical RBBB LBBB pattern. No. Then see this one. These are characteristic features of VT. Concordant meaning we have learned all the R positive from it or R are negative, and this onset of R to nadir is more than 100 listen. This is known as Brugada's sign. No, Brugada's sign. We have learned Brugada's sign. So Brugada's sign and Josephson sign. Brugada's sign, Josephson sign, and concordant things, all this favor VT if these are present. Okay, this is also gone. So typical RBB you see, and if typical signs of VT you will see. Then this is atypical RBBB and atypical LBBB. These are atypical. Atypical RBBB and atypical LBBB. What is that? We will see. In RBBB, what you will see is in V1, you will have small q and it will be broad. Okay, small q and R like this, or R will be more and small s like this. Okay, or it will be like this. R will be more and R dash in V1. So this is atypical RBBB. In all these things you are seeing, RBB is very much taller. So R taller RBBB, R taller RBBB, R taller RBBB. Okay, either QR or RS or R dash. So R is taller, so RBBB. Atypical RBBB. So that favors VT. That is atypical RBBB, and so R will be taller and Q smaller and S will be shorter. That is atypical RBBB. What is atypical LBBB? So R wave in V1 will be more than 30 milliseconds, nothing but 1 point, I can say 140, okay, half. It is actually 30 milliseconds means not one small. If you take one small square, it will be more than 2/3 of that one small square. 2/3 of one. Why? Because one small square is equivalent to 40 milliseconds. 2 small square 80 milliseconds. 2.5 small squares 100 milliseconds. That's why I am saying if it is more than R wave is more than 2/3 of the one small square, or this is again R to nadir of S. This is more in V1 is 60 milliseconds. 60 milliseconds. This is a 1.5 small square. 1.5 small square. So this is R and this is S. Calculate this distance from this to this. If this distance is more than 1.5 small squares, then it is LBBB pattern. Where? In V1. Okay, in V1. In RB, and remember this atypical LBB, atypical RBB. Atypical RBB, R will be taller. Atypical LBB, R will be wider. I think R will be wider, and you should calculate. Remember like this. In atypical LBBB, you will see whenever there is LBB, you will see V5 V6. No, first you see first V5 V6. So you notice here the Q is small, but either R or S will be taller. So the pattern can be like this: Q R, and it will be very longer, no, like this. Okay, or it will be like this. something. So this is QR and this is QS. QS meaning it will be QR, no? QR or QS in V6. Okay. That's about the features of SVT. So wide complex, irregular, be happy. Wide complex, ask previous ECG, ask history of any structural heart disease, see AV dissociation. Okay. Then see RBBB, LBBB pattern. So these are the 4 points you to remember. If it is regular, 1 point is second point. This is the first point, this is the second point, this is the third point, and these are all 4 points. First point, previous ECG you compare. Second point, history of anything you compare. Third point, AV dissociation you will see. Now you will see the typical RBBB pattern or atypical RBBB pattern, which we have learned. So that's about these flow charts. Now we will move on to the treatment. Okay. Principles of management, general business management. Treat the reversible cause, as I've discussed in the previous class also. 1, 2, 3, 4, 5. 5 causes, important causes of arrhythmia. Remember, number 1, ischemia. Number 2, electrolyte disturbances like potassium, magnesium, calcium. Okay. Number 3, drugs. Number 4, hypoxia. Number 5, hyperthyroid, or you can remember like this: ischemia, electrolyte, drugs, oxygen, TSH. These are the 5 important causes you should bear in mind. Okay, ischemia, electrolytes, drugs, ischemia, electrolytes, drugs, ischemia, electrolytes, drugs, ischemia, electrolytes, drugs, oxygen, and TSH. Then what is the acute management? Remember, any complex, whether it is SVT or VT, if they are unstable, cardioversion, DC cardioversion. If they are stable, then only you will give drugs, pharmacological drugs, pharmacotherapy. If they are unstable, electrical therapy. Okay. What is the acute management? Unstable patient, like if the patient has hypotension, heart failure, also syncope, ischemia. Okay. So this is CVS symptom, these two, and this is CNS symptom. So any CVS or cardiovascular or CNS symptom, you synchronize cardioversion. If it is tachycardia or if it is bradycardia, you should do pacing and chronotropic effect for bradycardia. Chronotropic, you go pacing you will do. Temporary pacing, pacemaker you will. Pacing you will do, okay. If it is stable, then drugs will have a role. Stable patient, narrow complex tachycardia. First you will try vagal maneuvers. Second you will try adenosine. Third, so this is the first one, this is the second one. Alternatives are IV beta blockers, this is the third one, and fourth one is verapamil and diltiazem. That is narrow complex. Wide complex tachycardia, diagnosis is uncertain. Give either these two are important drugs, procainamide or amiodarone. Okay, no, nothing you know. Okay, and avoid verapamil, diltiazem, adenosine, as they can cause hemodynamic collapse if the rhythm is ventricular tachycardia. So you can give procainamide and amiodarone. That's all. Bradycardia, atropine for symptomatic bradycardia, and temporary transcutaneous and transvenous pacing for high grade AV block. For example, 3rd degree AV block. Long term management I will do. So you remember Vaughan-Williams classification in pharmacology. So all these electrolytes will play a role for for maintaining cardiac action potential. So these drugs, so main electrolytes are sodium, potassium, and calcium. These 3 are the main electrolytes, and AV node also. So these are the main things which play a role. So you will give sodium blockers, potassium blockers, calcium channel blockers, and AV nodal blockers. So class 1 are nothing but sodium channel blockers. blockers. Which are those? They can be classified as 1A, 1B, 1C. Okay, we'll see in the next chart. Okay, remember in this procainamide, flecainide, propafenone, one important thing is 1C agents, nothing but flecainide and propafenone should not be used in structural heart disease because they are proarrhythmic. Class 2 are beta blockers, AVNRT, okay, metoprolol, bisoprolol. These are first line for SVTs. Okay, then class 3 are potassium channel blockers. So amiodarone is the very important drug in class 3 potassium channel blockers. This is effective, but this has organ toxicity. Sotalol is the next important drug, amiodarone, sotalol. So others are dofetilide, ebutilide. Okay, but what is the important one? They prolong the action potential. Remember this the cardiac action potential. You remember, no? So this repolarization phase is caused by potassium only, no? Potassium channels. So you are blocking the potassium channels. So you will prolong the repolarization phase as well as the refractive period. So you will prolong the PR interval because prolong the QT interval. Sorry, because QT interval signifies the repolarization phase. Okay, again this is a bad thing because it can trigger Torsades depointis. Class 4 are calcium channel blockers, verapamil, diltiazem. Okay, others are digoxin and adenosine. So where they will act? So this is a diagram showing where they will act. So beta blockers, verapamil, diltiazem, if you take, it will act on and atropine. This will act on AV node. Okay, and on drugs which are acting on AV node are these four. On SA node, this is SA node. On AV node, again same beta blockers, verapamil, diltiazem. You add 2 to this, adenosine and digoxin. Adenosine and digoxin. Adenosine and digoxin. Adenosine and digoxin in AV node. Okay. Now, which act in atria also, ventricles also, and accessory conduction tissue. This is important. Accessory conduction tissue. So you are seeing amiodarone will have effect on accessory conduction tissue. Flecainide and propafenone also can be used. This is 1C drugs, no? 1C drugs. But these are proarrhythmic. They should not be used in structural heart disease patient. So you basically amiodarone you can use. But one more drug you should remember, that is procainamide, which is which acts on this accessory pathway also. But remember, this is the drug of choice for AF with accessory pathway, AF with antidromic conduction. Antidromic conduction. What is this AF with antidromic conduction? This is nothing but here will be the accessory pathway and there will be many circuits in the atria in atrial fibrillation which are firing. So instead of taking this path, they will take this fast path. So this will cause ventricular tachycardia, serious ventricular tachycardia, and this is an emergency. So for that only one drug is approved, that is procainamide. So AF, if it is taking antidromic conduction from the accessory pathway, that is very dangerous. Okay, for that procainamide drug is approved if the patient is stable. Not stable, again DC cardioversion. So and ventricles, beta block, lidocaine is important, and beta blockers can also lidocaine and beta blockers, mexiletine. So these are the drugs which act. So this is a diagram, important diagram of Vaughan-Williams classification from Oxford book. So see here, procainamide which you use, AF cardioversion you can use, VT termination, important drug. Remember the dose, oral dose. Because it is a hypotension, it can cause J abscess, lupus like syndrome it can cause. Okay, see class P, lidocaine, again it acts on ventricles, no? So ventricular VT termination and VT-VF prophylaxis you can use. Okay, 100 mg bolus and 1 to 4 mg, this is the dose. CNS side effects, dysertria and fits. CNS effects, lidocaine usually cause, lignocaine usually cause CNS side effects. Okay, class 1C, flecainide, propafenone. Mainly these are used in atrial fibrillation and WPW syndrome prophylaxis. Mainly these are used in permanent atrial fibrillation. Okay. Then class 2 is the bisoprolol. Again, in SVTs, ventricular the prophylaxis of this, they are used. Beta blockers. You can go through this flow chart. Then class 3 important drugs are amiodarone and sotalol. These are wide, broader activity drugs. They are useful in SVTs also and VTs also. Okay, for prophylaxis and termination also. Okay, prophylaxis and termination, SVTs also and VTs also, because amiodarone is important. You just remember the dose, 300 mg bolus you will give in 5% dextrose you will give, because if you give in NS it will precipitate. 5% dextrose in 100 ml NS, you will dissolve this much of drug and give in half to 1 hour. After that you give 9 mg 20 hour. Okay, that is IV. In oral, loading dose is 0.6 gram to 1.2 gram per day for the first 15 days. 0.6 to 1.2 gram for the first 15 days, then 100 to 400 mg per day. So remember the side effects of this drug, because this is used very much now. Bradycardia it can cause, skin problems it can cause, lung problems it can cause, thyroid problems it can cause. They're all, and nerve problems it can cause. Verapamil SVTs you use. Okay, IV 5 to 10 mg. This is oral dose. Okay, it can induce AV block. Constipation is the important side effect. Okay, other drugs, digoxin, AF rate control. Remember, cardiac failure, acute heart failure with AF, digoxin is the drug of choice. Digoxin is the drug of choice. Dose this much, and you should have a you should give for 6 days and 1 day holiday. 1 day holiday to avoid toxicity of this digoxin. It is a pro-arrhythmic, no, digoxin is pro-arrhythmic also. And one important point about digoxin is, the first sign of digoxin toxicity is nausea and vomiting. This is the first sign. Okay, this is the first sign of digoxin, nausea and vomiting. Adenosine, SVC termination also, and diagnostic also. 6 mg up to, you can give up to 18 mg. That means 6 3 18. 3 doses you can give. Very short acting drug. Ideally should be a central line, but if you are preferring peripheral line, just after giving, just you raise the hand like this fast. Short, very short acting drug, very short acting drug. Okay. And one more important word for adenosine is, it induces bronchospasm, so it is contraindicated in asthma patients. What? Adenosine is contraindicated. That's about acute therapy. Long-term management, sorry, long-term pharmacological therapy. Long-term pharmacological therapy. Non-pharmacological therapy are, just I will point out, catheter ablation. This is a catheter ablation, or the foci which are firing, which are causing this arrhythmia, either from ventricles or from the atria. You just ablate those. So that catheter ablation. Okay. That uses radio frequency or cryo energy, cold, heat or cold energy to destroy this. So catheter ablation. Second is electrical devices. Include permanent pacemaker for bradycardia, sinus node dysfunction, and AV blocks, or implantable cardioventricular defibrillator (ICD) for secondary prevention or primary prevention in high risk of lethal ventricular arrhythmias. Ventricular arrhythmias. Low, high risk meaning low ejection fraction, less than 35%, or genetic syndrome. So primary prevention and secondary prevention. Primary prevention, high risk patients. Secondary prevention after sudden cardiac arrest, ICD. Cardiac resynchronization therapy. Biventricular pacing is done to improve the synchrony function in heart failure patients with LBBB, low ejection fraction. So this is for bradycardia, and these two are for tachycardia. So by this we end our arrhythmia series, and I am comfortable that uh, even though if someone is listening or not listening, I have learned many things about arrhythmias now. Thank you, and do share if you like. Thank you for your listening. May Allah accept these efforts. Ameen.